Ever get that nagging feeling, that stiffness that just won't quit, especially maybe first thing in the morning? Today, we're diving deep into a condition that affects, well, quite a lot of people, often without them fully understanding what's going on. Ankylosing spondylitis, or AS?
Yeah, AS. It's about unlocking the puzzle of this chronic back pain and stiffness for many.
Exactly.
Ankylosing spondylitis is a long-term inflammatory disease, and it really targets the spine primarily. We're talking pain, stiffness, and sometimes the vertebrae can actually fuse together.
Wow, okay.
Our goal in this deep dive is really to pull out the most important sort of high-yield information about AS.
Right.
So whether you're, revising this for exams or maybe learning about it for the first time, we want to make it clear, easy to grasp.
And it's had a few names over the years, hasn't it? I think I've seen rheumatoid spondylitis.
That's right. Rheumatoid spondylitis, Marie-Strumple disease, von Bechter's disease.
Right.
Those older names, they kind of give us some historical context, show how our understanding's evolved.
So today, we're going through it systematically.
Yep. We'll start with a clear definition, then look into what causes it, who's most at risk, what's actually happening inside the body, the pathophysiology, then how doctors tell it apart from other things, how common it is, the clinical signs, diagnosis, management.
The whole picture.
The whole picture.
Yeah.
Outlook, complications, everything based on our sources.
Okay, let's get down to brass tacks then.
Yep.
In simple terms, what is ankylosing spondylitis?
So at its core, AS is a chronic, that means long-term inflammatory disease, primarily attacking the spine.
Inflammation being the key word there.
Absolutely. This ongoing inflammation leads to that persistent pain and stiffness. And the big concern, really, is the potential for the vertebrae, the spinal bones, to fuse together.
Ankylosing, that means stiffening.
Exactly. Stiffening, becoming immobile, that's the ankylosing part.
Now, I remember reading something about a genetic link, HLA B27.
You're right on the money. AS has a really strong association with the HLA-B27 gene. Now, this is interesting. This gene helps your immune system tell what's self and what's foreign.
Right.
And the theory is, in some people with this gene, the immune system might mistakenly attack the joints in the spine.
Ah, so it's an autoimmune component.
It certainly seems like it involves immune dysregulation. But, and this is crucial, not everyone with HLA-B27 develops AS.
Okay, so it's a risk factor, but not a guarantee.
Precisely. It's a big piece of the puzzle, definitely, but not the only one.
So who typically gets AS then? Is there a common profile?
It tends to show up more often in young males, typically hitting between the ages of, say, 20 and 30.
Young men, okay.
Yeah.
And it affects the axial skeleton.
That's right, the axial skeleton, so your spine and pelvis primarily. We talk specifically about sacroiliitis.
That's the sacroiliac joints.
Yes, inflammation right where your spine connects to your pelvis. Think of it as the spine's foundation.
Wow.
And then spondylitis is the inflammation of the vertebrae themselves.
You also mentioned axial spondyloarthritis earlier. How does AS fit into that? Is it the same thing?
Good question. Axial spondyloarthritis, or axSpA, is sort of an umbrella term.
Okay.
Underneath it, you have AS, where the inflammation and damage in the sacroiliac joints are visible on X-rays. That's the radiographic part.
Right.
But there's also non-radiographic axSpA. That's where someone has the typical symptoms, the inflammation is there, maybe seen on MRI, but the X-rays don't show definite sacroiliitis yet.
So same underlying process, just different stages or visibility on X-ray.
Essentially, yes. Both involve that chronic inflammation in the spine, sometimes other joints, even organs.
Okay, that clarifies things. So we know what it is, but what actually starts it? The etiology.
Well, the cause, the etiology, it's thought to be a mix, really. A combination of genetic predisposition and environmental factors.
We've covered the genetic part with HLA-B27.
Right, the strong link is there. But like we said, it's not the whole story. You need something else, probably.
An environmental trigger.
It seems likely. There needs to be some kind of trigger in people who are genetically susceptible.
Like what?
Well, one interesting theory involves certain bacteria. For instance, Klebsiella, which you can find in the gut.
Klebsiella. How would that work?
The idea is, in someone with HLA-B27, maybe an infection with Klebsiella or perhaps changes in the gut microbiome involving it, could trigger an immune response that then cross-reacts and mistakenly attacks the spinal tissues.
Fascinating. Molecular mimicry, kind of?
Something along those lines, potentially. It's an active area of research.
So based on all that, what are the main risk factors then? Who should be more aware?
Okay, so the number one risk factor we keep coming back to is having that HLA-B27 gene.
Definitely.
Your odds are just significantly higher if you carry it.
And family history must play a role too, given the genetics.
Absolutely. A positive family history is a major risk factor. If a close relative parent, sibling, has AS, your own risk goes up considerably.
Makes sense. And you mentioned it's more common in men.
Yes, being male is an established risk factor. We see it maybe 2 to 3 times more often in men than women, though the reasons aren't fully clear.
Interesting. And those potential triggers, the infections.
Yeah, there's some evidence suggesting certain infections, maybe in the gastrointestinal tract or urogenital system, could act as contributing factors, especially in those genetically predisposed individuals.
Okay, so we have the risk factors. Let's talk pathophysiology. How does that initial inflammation actually cause the symptoms, the stiffness, the fusion? What's going on at a biological level?
Right, the pathophysiology. So you've got this chronic, ongoing inflammation hitting the joints and ligaments of the spine.
And that causes the pain and stiffness directly.
Yes, that inflammation is the primary driver of the pain and stiffness people feel, but over time it leads to something more profound, the fusion of the vertebrae.
That fusion sounds, well, pretty serious. How does inflammation lead to bone fusion?
It's a bit of a misguided repair process, you could say. The chronic inflammation signals the body to repair the damage.
Okay.
But in AS, this repair goes kind of haywire. Instead of just healing, the body starts laying down new bone in places it shouldn't.
Like bridging the gaps between vertebrae.
Exactly. Tiny, bony bridges, called syndesmophytes, form between the vertebrae. Gradually, these can solidify, fusing the vertebrae together. That's the ankylosis process.
And it's primarily the spine and sacroiliac joints, but not exclusively.
Correct. Those are the primary sites, definitely. But the inflammation can also pop up in other joints. Hips, shoulders are quite common, and sometimes even affect organs like the eyes, causing uveitis, or potentially the heart or lungs in the long term.
And it all comes back to the immune system going wrong and the genetic factors.
That's the core of it, yes. Immune system dysregulation interacting with those genetic predispositions, particularly HLA-B27.
Now, back pain is incredibly common. How do doctors figure out if it's AS versus, just a bad back or something else entirely? The differential diagnosis.
Yeah, that's a key challenge sometimes. The differential diagnosis is broad because many things cause back pain.
So what are the main contenders?
Well, first you have other types of spondyloarthritis, things like psoriatic arthritis, which often comes with skin psoriasis, or reactive arthritis, which typically follows an infection. These share some features with AS.
Okay, what else? More common stuff.
Definitely. You absolutely have to consider mechanical back pain, muscle strains, disc problems, especially if the pattern doesn't quite fit AS.
Like if it gets better with rest instead of worse.
Exactly. Also, other inflammatory conditions like rheumatoid arthritis, though it usually affects peripheral joints more. And degenerative conditions are huge differentials, especially in older people, osteoarthritis, degenerative disc disease.
Any less common things to keep in mind?
Yes, though rarer, you need to rule out infections affecting the spine, like spinal TB or even spinal tumors, though these are much less frequent.
What about things like fractures or...
Good point. Spinal fractures, especially vertebral compression fractures if there's underlying osteoporosis, which can happen with AS. Also, infectious sacroiliitis, spinal stenosis narrowing of the spinal canal, or even referred pain from other areas. Congenital spinal issues too sometimes.
So quite a list to work through. How common actually is AS in the population? What are the epidemiology figures?
In the UK, the estimates are around 0.5% to 1% of the population, so not super rare, but not extremely common either.
And sticking with the pattern, more common in men.
Yep, consistently more prevalent in men. And typically, as we said, onset is in late adolescence or early adulthood, usually before age 45, often much younger.
Is that pattern similar worldwide?
Broadly, yes. Global prevalence varies a bit, maybe higher in some Northern European populations, perhaps lower in some parts of Asia and Africa. But the trend of male predominance, usually around 2.1 or 3.1, holds true pretty much everywhere.
And that genetic link, HLA-B27, is that found globally too?
Yes, the association with HLA-B27 is strong worldwide, although the frequency of the HLA-B27 gene itself varies in different populations. But where AS occurs, HLA-B27 is usually strongly implicated.
The heritability being over 90% really emphasizes that genetic component.
It absolutely does. It's one of the most heritable rheumatic diseases. But again, it's not just HLA-B27. Other genes are likely involved too. The typical onset age, 20 to 30, is also pretty consistent globally.
Okay, so let's talk clinical features. If someone listening thinks, this sounds a bit like me, what are the classic signs and symptoms they or their doctor should look for?
The absolute hallmark is chronic lower back pain and stiffness. Especially in a young man, that's a big red flag.
But it's a specific kind of pain and stiffness,
Ye-
right?
Yes, the pattern is key. It's typically inflammatory back pain. That means it's usually worse in the morning, often lasting more than 30 minutes upon waking.
Okay.
Crucially, it tends to improve with exercise and movement, but gets worse with rest.
That's counterintuitive for some back pain.
It is. And often people experience pain at night, sometimes waking them up in the second half of the night, but it improves once they get up and move around.
That morning stiffness improving with movement, that sounds critical. Any other physical signs?
Yeah, limited spinal mobility is a really important finding on examination. How well can you bend your back forward sideways twisting that often becomes restricted?
What about more general symptoms?
Yes, systemic symptoms like persistent fatigue are very common and can be quite debilitating. Unintentional weight loss can occur too.
And does it affect other parts of the body?
It can. Pain and swelling in other joints like the hips, shoulders, knees, or ankles. And eye inflammation, uveitis or uveitis, is quite common, causing eye pain, redness, light sensitivity, blurred vision.
And it comes on gradually.
Usually, yes. It's typically a gradual onset, insidious, and it tends to progress over time if not managed effectively.
Are there specific criteria doctors use for diagnosis?
Yes, the modified New York criteria are often used. They combine clinical findings, the symptoms and signs, with radiological evidence from X-rays.
Can you break those down? What are the clinical parts?
Sure. The clinical criteria are 1. Low back pain for more than 3 months that improves with exercise but not rest. 2. Limitation of movement in the lumbar spine in both forward bending and side bending. 3. Limitation of chest expansion compared to normal values for age and sex.
Okay, and the radiological part?
That's evidence of sacroiliatis on X-ray. It's graded, but essentially showing inflammation or damage in those sacroiliac joints.
So how do you put those together for a diagnosis?
For definite AS, you typically need the radiological criterion, sacroiliatis on X-ray, plus at least one of those 3 clinical criteria.
And probable AS?
Probable AS could be having all 3 clinical criteria without definite X-ray changes, or having the X-ray changes but none of the clinical criteria, although that's less common. Nowadays, MRI helps identify earlier stages too, before X-ray changes are clear.
When should someone with these kinds of symptoms really push to see a rheumatologist?
Referral should definitely be considered if you have inflammatory type back pain starting under age 45, especially if it lasts over 3 months. Also, if there's a family history of AS or related conditions like psoriasis or IBD, if the pain responds well to NSAIDs but comes back when stopped, or if you have associated features like uveitis, enthesitis.
Enthesitis, what's that?
That's inflammation where tendons or ligaments attach to bone. Common spots are the Achilles tendon or the sole of the foot. Plantar fasciitis. Dactylitis or sausage digit is another clue.
And what's the typical disease course? Is it always progressive?
It varies a lot. Some people have relatively mild chronic disease. Others have intermittent flares with periods of remission. Systemic features like low-grade fever, fatigue, weight loss can sometimes accompany flares.
What about severe outcomes?
In severe, often untreated or poorly controlled cases, the long-term outcome can involve significant spinal fusion, leading to a stooped posture, sometimes called kyphosis, and restricted chest expansion, which can affect breathing.
Okay, so if ACAS is suspected, what investigations are typically done to confirm it and assess things?
Investigations basically fall into diagnostic ones, imaging and blood tests, and then others for monitoring or specific issues.
Let's start with imaging. X-rays first.
Usually, yes. Pelvic X-rays specifically looking at the sacroiliac joints. Early on, they might be normal.
But later?
Later, they can show characteristic changes, blurring of the joint margins, erosions, sclerosis, hardening of the bone, and eventually a partial or complete fusion of the sacroiliac joints. In the spine, X-rays might show squaring of the vertebrae, those syndesmophytes forming bony bridges, and ultimately the classic bamboo spine appearance if there's extensive fusion.
What about MRI? You mentioned it's good for early detection.
Exactly. MRI is much more sensitive for picking up early inflammation. It can show bone marrow edema, essentially inflammation within the bone in the sacroiliac joints and spine, long before X-ray changes are apparent. It's really valuable for confirming suspected axSpA when X-rays are negative or equivocal.
And blood tests, what they show.
Blood tests are more supportive than diagnostic on their own. Inflammatory markers like ESR and CRP are often elevated, especially during active disease, but they can be normal too.
Not specific then.
Not specific at all. They just indicate inflammation somewhere in the body. HLA B27 antigen testing is done routinely. It's positive in about 90% of people with AS in Caucasian populations, but remember, having the gene doesn't equal having the disease.
Anything else in bloods?
A full blood count might show a mild normochromic, normocytic anemia, which is common with chronic inflammation. Mostly, blood tests help rule out other conditions.
Any other tests sometimes used?
Occasionally, spirometry, lung function tests, might show a restrictive pattern if chest expansion is severely limited due to rib cage fusion or kyphosis. DXA scans are important for monitoring bone density, as osteoporosis is a known complication. Musculoskeletal ultrasound can be useful for looking closely at enthesitis.
Right. So once the diagnosis is made, how is AS managed? What are the goals?
The main aims are 1. Relieve symptoms like pain and stiffness. 2. Maintain mobility and function as much as possible. 3. Prevent or manage complications.
And it needs ongoing care.
Definitely. Regular monitoring and a multidisciplinary approach are key. That means input from rheumatologists, physiotherapists, occupational therapists, maybe others depending on the person's needs.
What about non-drug treatments? Exercise.
Exercise and physiotherapy are absolutely fundamental. They're not optional extras, they're core treatment.
What kind of exercise?
Regular exercise tailored to the individual. Swimming is often recommended because it's low impact but works on range of motion and fitness. Specific physiotherapy programs focusing on spinal mobility, stretching, strengthening core muscles, and postural training are crucial.
Posture is important.
Very important to counteract the tendency towards stooping. Sometimes, for severe cases, intensive inpatient rehab programs might be beneficial.
Okay, moving on to medications. What's the first step usually?
First-line treatment for symptoms is typically non-steroidal anti-inflammatory drugs and NSAIDs. Ibuprofen, naproxen, diclofenac, etc. They help reduce both pain and inflammation.
Are there concerns with long-term NSAI use?
Yes, potential gastrointestinal side effects like gastritis or ulcers are a concern. So often a stomach-protecting drug like a proton pump inhibitor, PPI, is co-prescribed. Or sometimes KIOX2 selective NSAIDs are used, which might have a slightly lower GI risk, often still with a PPI if risk is high.
What if NSAIDs don't work well enough or can't be tolerated?
Then other pain relief options might be needed, like simple analgesics, but they don't tackle the inflammation. For troublesome morning stiffness, a slow-release NSAI taken at night can sometimes help. If pain disrupts sleep, adding something like low-dose amitriptyline might be considered.
What about corticosteroids like prednisone?
They have a role, but it's usually limited. Local steroid injections into inflamed sacroiliac joints, peripheral joints, or sites of enthesitis can be very effective for localized problems.
Oral steroids.
Short courses of oral steroids might be used occasionally for severe flares to get things under control quickly, but long-term oral steroids are generally avoided in AS. They don't really modify the disease progression in the spine effectively and carry significant side effect risks, including worsening osteoporosis.
Okay, then we get to the biologics, the cytokine modulators.
Yes, these have been a game changer for many people with AS whose disease isn't controlled by NSAIDs. The main group are the TNF-alpha inhibitors.
Like adalimumab, etanercept.
Exactly. Adalimumab, certolizumab pegol, etanercept, golimumab, infliximab. TNF-alpha is a key inflammatory protein, and these drugs block it. They are prescribed by rheumatologists, and response is usually assessed after about 12 weeks.
Are there other options if TNF inhibitors don't work or aren't suitable?
Yes, there are IL-17 inhibitors like secukinumab and ixekizumab. Interleukin-17 is another important cytokine in AS inflammation. These are options if NSAIs or TNF inhibitors haven't worked well enough. More recently, JK inhibitors like upadacitinib have also become available, offering another mechanism to target the inflammation.
Is surgery ever needed?
Surgery is generally reserved for specific complications or very severe deformity. For example, if someone develops severe kyphosis, that extreme forward bending of the spine that significantly impacts function or quality of life, complex corrective spinal osteotomy and stabilization surgery might be considered, but it's major surgery with significant risks. Hip replacement might be needed if the hips become severely damaged.
Looking at the bigger picture, what's the long-term outlook, the prognosis for someone with AS?
It really varies a lot from person to person, but overall with early diagnosis, access to effective treatments like physiotherapy and biologics when needed, and regular follow-up, most individuals with AS can lead productive, relatively normal lives.
What factors influence how someone does long-term?
Several things. The inherent variability of the disease course. Some people have much more aggressive disease than others. The presence of extraspinal manifestations like uveitis or IBD can impact things. Age at diagnosis might play a role, and certainly the effectiveness of and adherence to treatment are crucial. Any damage that occurs, like fusion, is generally irreversible, so preventing progression is key.
Finally, let's touch on the potential complications. What can happen down the line?
Well, the spinal fusion itself is a major complication, leading to loss of mobility and potentially that fixed, stooped posture.
Physically limiting, obviously.
Very. Chronic pain and stiffness are persistent issues. Reduced lung function can occur if the chest wall becomes rigid. Eye inflammation, uveitis, can recur and potentially damage vision if not treated promptly. There's a significantly increased risk of osteoporosis, making spinal fractures more likely, even from minor trauma.
Any other systems affected?
There appears to be an increased risk of cardiovascular disease, heart attacks, strokes possibly linked to the chronic inflammation. Hip joint involvement is common, affecting maybe up to a third of patients, sometimes requiring hip replacement. Neurological complications like Cauder-Equina syndrome, though rare, can happen due to dural inflammation or spinal stenosis.
And complications from the treatments themselves.
Yes, important to remember those. NSAIDs carry risks of stomach ulcers, kidney problems, and cardiovascular effects with long-term use. Biologic drugs suppress the immune system, increasing the risk of infections, and there are ongoing discussions about any potential long-term malignancy risk, although generally considered small.
All of this must impact daily life significantly.
Absolutely. The combination of pain, stiffness, and fatigue can have a major impact on quality of life, affecting work productivity, physical function, sleep, mood, and social activities. It's a condition that impacts the whole person.
So, to sort of wrap up our deep dive on ankylosing spondylitis, it's this chronic inflammatory condition, mainly hitting the spine, strong genetic links, especially HLA-B27, leading to pain, stiffness, potentially fusion.
Now, that's the core of it.
And the key seems to be early recognition, getting that diagnosis, and starting consistent management exercise, meds if needed, to really improve outcomes and help people maintain a good quality of life.
Exactly right. And it's worth stressing that research is ongoing. Our understanding of AS, the treatment options, it's constantly evolving, which offers hope for the future. Staying informed is really important.
Definitely. And if you, listening, want to delve deeper or find some excellent resources and support, do check out PathMSRA.com. That's PathMSRA.com.
And also freemsra.com, that's FREEMSRA.com. Both are fantastic resources for learning more.